So as we know, MGUS and Smoldering are precursor conditions for multiple myeloma, and all patients are preceded by these conditions, but these conditions are pretty common. 5% of the population above age of 60 have these alterations. So the question is, which are the ones that progress and which are not? Which are the ones that we should follow in our outpatient, and the one that can just be checked by the general practitioner once per year? So to answer this question, we develop a very large collaborations with multiple institutions such as Mayo Clinic, University of Miami, MD Anderson Cancer Center, Moffitt Cancer Center, University of Milan, and Memorial Sloan Kettering to assemble a large cohort of 374 patients with Smoldering on MGUS with available genomic and clinical information. We developed the concept of malignant transformation, which I think it's a key step forward for our understanding of what and how multiple myeloma developed. So the malignant transformation has the same logic of solid tumor. In solid tumor, if you have a polyps in the GI or nodules in the breast, and you find that this is tumor, is transformed with malignant cells, you call that carcinoma in situ. If you don't see the signatures, you call it benign nodule. So in myeloma, we don't have this definition. We call them Smoldering or MGUS, which are basically, we don't know what's going to happen. And so with this genomic classification based on the DNA alterations, we found that a significant fraction of Smoldering and part of MGUS are already like myeloma genomically. So they are already tumor. So they are transformed. That doesn't mean they will progress in 5, 3, 4. They can progress in 10 years. We have a patient with a full transformation that progress after 15 years. So that's another important aspect is why this transformed tumor takes 15 years to progress. So the answer is because probably there is some immune control, and understanding in the future this immune control will create the condition for developing more sustained and durable responses. On the other hand, the patient without malignant transformation, they never progress. So we can identify this population, and that's a potential clinical relevant implication. Finally, for the patients with that risk of progression with a tumor transformation, we also identify a clinical and genomic integrated signatures to predict the patients that will progress within 2-3 years. So the question now is, if these patients are progressing so fast, probably the immune control in those patients is lost, and so what should we do? Should we do immunotherapy like single agent, or should we treat them with more aggressive myeloma treatment? Of course, these are important questions, a lot of work to be done, but we're very grateful of being part of a great team of collaborators, and collaboration and network is everything in this field, and we're very glad to be part of it.